Good afternoon. This is a courtesy announcement that this meeting is now broadcast on our web portal and YouTube.
Good afternoon, Christine. Would you like to do a quick mic check? You are muted.
There we go. Good afternoon. How does that sound?
Loud and clear. Thanks so much. And Tyler, would you like to do a quick mic check?
Can you hear me okay?
I can. Thank you.
All right.
Good afternoon, Bert. Would you like to do a quick mic check?
How about now? Can you hear me?
Well, sure can. Thanks so much.
Okay, thanks.
Bert, do you have any slides today? Just confirming.
No, thanks for confirming. I do not have slides.
Perfect. Thank you.
Sure.
Good afternoon, Laura. Would you like to do a quick mic check? You are muted.
Sorry about that.
No worries. Loud and clear now.
Thanks.
Recording in progress.
Good afternoon, Chairperson Smithian.
Good afternoon. And Jess, are you our clerk today?
I am.
Thank you for your assistance.
You're very welcome. The recordings are on. We are ready when you are.
All right, I will silently count to 3. All right, ladies and gentlemen, thank you very much. This is the special hearing of our Santa Clara County Health and Hospital Committee today. We are having a special hearing on Medi-Cal managed care, and I'll share a little bit more about that in just a moment. But first, let's call the roll and establish the presence of a quorum. Thank you.
Vice Chairperson Lee.
Good afternoon, Lee present.
Chairperson Smithian.
Here. Thank you very much. Both members of the committee are present. We welcome the members of the public and the staff who've joined us as well. Supervisor Lee, a fairly focused agenda today. Item number 2 ordinarily would be to approve changes to the committee's agenda, but I'm not aware that any are called for. Without objection, we will accept the agenda order as presented. Good enough?
Perfect.
All right, thank you. Then that takes us directly to our agenda for this special hearing. And initially we have a 2-person panel, and I'm very pleased to welcome both of them. This is a panel discussion that relates to impending changes to Medi-Cal managed care, which will include but not be limited to the requirements of a procurement or reprocurement process for the commercial managed care plan in our 2-plan system. Some of the proposed reforms under CalAIM, the California Advancing and Innovating Medi-Cal, and the proposal to allow Californians who are income eligible to receive Medi-Cal that the governor has just announced. So we have at least 3 very big things going on in the world of Medi-Cal managed care. And forgive my virtual PowerPoint here, but we've got a procurement and potentially a new partner in the 2-plan system. We've got the changes of CalAIM, and we've got the potential significant growth in the Medi-Cal eligible population. Plus, I'm sure there are some other things that I have not thought to mention. So we're going to welcome our 2 panelists here, Melora Simon and Bert Margolin. Ms. Simon is a senior strategist with the California Healthcare Foundation. I hope she and Mr. Margolin will forgive me if I don't delve deep into their CVs, but suffice it to say, we thought we were quite fortunate to get these 2 folks to join us today and share what they see on the horizon. And Supervisor Lee, I have asked folks to think about this in the context of, all right, at least 3 big changes headed our way, maybe more, and if so, please share. But what does that mean for our county? What kind of policy choices does that mean we're likely to face? What kind of budget choices are we going to have to face? How will this change the nature of our responsibility and the work that we do? And with that, let me see if we can pull Melora Simon in to share her thoughts initially, then followed by Mr. Margolin, and then we'll have questions from for the 2 panelists from the 2 members of the committee. That would be you and me. And let me turn to our clerk and ask if Ms. Simon is with us.
She is.
All right, Ms. Simon, we'll ask the clerk to enable you and look forward to hearing your thoughts. Thank you again for being with us. Appreciate you making time.
Thank you very much.
There you are.
Excellent. And can you all see my screen?
Yes, we can.
Fantastic. So before I jump into my presentation, which is focusing on the CalAIM program, I just want to say a little bit about the California Healthcare Foundation, which is the organization that I work for. We're an independent nonprofit foundation that works to improve healthcare for all Californians. And we're especially focused on the Californians that live with low incomes and others that are not served well by the current system. And because of that, we're focused on Medi-Cal, and we're really excited and interested in CalAIM because we think it represents an unprecedented opportunity to integrate care for people with complex needs and enhance equity in the system. There we go. And just before I jump into CalAIM, I thought it would be helpful to do a little bit of just table setting around the Medi-Cal system and the Medi-Cal program because it's quite complex. So it's a source of financial stability for nearly 3 million low-wage workers across the state. It covers care for half of births, half of Californians with disabilities, and more than half of the state's school-age children, and more than 1 million seniors, and 2/3 of patient days in long-term care facilities. It's really the cornerstone of our mental health system, and perhaps the state's most powerful tool for treating drug and alcohol addiction, and for addressing health challenges associated with homelessness. And last but not least, almost 1 in 4 Black Californians and more than 1 in 3 Latinx Californians are enrolled in Medi-Cal. So it has an outsized role to play in driving health equity in the state. And Medi-Cal is also very comprehensive. It's more comprehensive than commercial insurance or Medicare. So it not only covers doctors and hospitals and therapists and prescriptions, but it also covers over-the-counter medications, long-term care in a nursing home, family caregivers, transportation to and from the doctor's office and pharmacy, and medical equipment like wheelchairs, canes, and breast pumps. And yet it's not a single program. Medi-Cal spans at least 4 different departments within Sacramento's Health and Human Services Agency. And to deliver services, Medi-Cal relies on 24 distinct managed care plans, numerous agencies in 58 county governments, and more than 130,000 Medi-Cal providers of every type. So we may think of it as a single system, but it's actually quite complex. And that really leads us to kind of why CalAIM is important. So over the years, Medi-Cal has grown up, and a wide range of reforms have been introduced to improve care for specific groups. But those really well-intentioned reforms have sometimes had the unintended consequence of creating more fragmentation and complexity. And so the metaphor that works for me in trying to understand this is kind of imagine if when you went to go grocery shopping, you not only had to go to different stores to get proteins, fruits, grains, and vegetables, but you had to pay with different credit cards and navigate different rules about what you could buy when and from whom. And not all stores would take your cards, but they might only take your card if you come directly from another store with a specific piece of paper. And that wouldn't be so bad if you were making something simple, like grilled chicken. But let's imagine you're trying to get everything you need for a Thanksgiving dinner. Except that it isn't about cranberry sauce and stuffing. It's about getting the care that you need for your health. And for many people covered by Medi-Cal, it isn't as simple as getting in your car and going shopping. Maybe you're in a wheelchair, or maybe English isn't your first language, or maybe you're really struggling with depression or with another chronic condition that makes all of this that much more challenging. In addition, Medi-Cal today is very comprehensive when it comes to healthcare, but it doesn't always address the social risk factors that we know are so important to our health outcomes. And that sometimes results in us paying more downstream rather than making a small upfront investment. So 2 really classic examples of this is that Medi-Cal will pay for someone to live in a nursing home, but has not historically paid for the ramp to be built that would enable them to stay in their home if they were in a wheelchair. Or Medi-Cal will pay for the ER visit to resolve an asthma attack, but not the mold removal that would eliminate the allergens that caused the attack in the first place. So that brings us to CalAIM, which is really an unprecedented effort to fix all this. And at its core, CalAIM is about moving from a system that treats individual conditions to one that treats the whole person, creating less inefficiency and more value, both for the enrollee and for the system and the taxpayer. And it isn't starting from scratch. It builds on years of effort and years of experimentation and innovation in counties like Santa Clara, taking the success from the Whole Person Care Pilot and the Health Homes program and spreading it across the state in an equitable way so that no matter where people live, no matter how or where they seek support, all people with Medi-Cal coverage can get what they need in an integrated way. It's really about coupling clinical care with non-clinical services in more flexible ways. And it's about systemic equity, changing the frame so that the onus is on the system to proactively identify gaps and disparities rather than just responding to whoever comes in the door or knocks the loudest. And it's very exciting that CalAIM comes at a time when there's a proposal to expand Medi-Cal coverage to all people who qualify based on income. It really speaks to the importance of Medi-Cal and the opportunity to have a coherent system for all. But let's get concrete. It's a 5-year program. And I think it's probably helpful to really start with some of the changes that are happening this year and next year to help understand the implications and opportunities and risks. So in terms of 2022, there's really kind of 4 main changes that are happening, and I'll go through each one, but they are enhanced care management, community support, PATH, or providing access and transforming health, and then some reforms to the behavioral health system. So I'll start with enhanced care management. This is a required statewide benefit that really builds on the health homes program. It's delivered through managed care, and it's part of a broader population health strategy that's going to be fully implemented in 2023. So ECM, or enhanced care management, is starting at the very tippy top of the pyramid in terms of people's needs, and it's the highest intensity level of coordination and care management that we see. It's intended to be high touch and in person, delivered at the point of care, in person by community-based providers, so not by the managed care plan. It's whole person in all services, so again, not just those covered by managed care. And it starts with outreach and engagement, goes through care planning, transitions between settings, and closed loop referrals to all services, and it also takes into account the entire family. In 2022, there are 3 populations of focus that are being rolled out statewide: people experiencing homelessness, adults with serious mental illness and substance use disorder, and adults who end up using a lot of acute services. There are more to come in 2023. So that's ECM. Community supports really fits hand in glove with ECM, so that as your care manager gets to know what your needs are, they have the flexibility to offer you the things that you might need that would fill in the gaps and help avoid those institutionalizations or costly outcomes and crises. They're designed to support people in the community instead of in institutions. And plans have been offering these sporadically for a while, but now they can be reimbursed for them for the first time. However, they have to balance that against what they would have offered instead. So they're optional for both plans and enrollees. There's a menu of 14 pre-approved services. They fall into 3 buckets: housing supports, which includes navigation, deposits, and tenancy and sustaining services to help people hang on to their housing if they're at risk of losing it. Short-term recovery and respite supports. So here you've got recuperative care or medical respite and short-term post-hospitalization housing for people experiencing homelessness. You've got sobering centers, which provide an alternative to jails or to emergency rooms for people to dry out. And then you've got caregiver respite. So the opportunity to have somebody in a facility for a short time to give some respite for a caregiver. And then finally, a set of independent living supports. So medically tailored meals, home modifications and asthma remediation, rehabilitation programs, which help people learn the skills of independent living. And then finally, personal care and homemaker services for people who need ongoing support with those activities of daily living. In terms of how this is going to play out in Santa Clara, the Department of Healthcare Services recently published each plan's timeline for introducing these community supports. The services will build over time, as will the populations and enhanced care management. And what we see is that in Santa Clara, this is actually going to be fairly quick. By 18 months from now, all 14 services will be offered by both plans. That is unique in the Bay Area and pretty rare across the state. In general, we're seeing the commercial plans offering more services more quickly, perhaps because of the competitive pressures of reprocurement. We're saying for a minute here that even though these services are optional and voluntary for plans, there's really, really strong incentives from the department to help get plans offering them and implementing them in a way that enhances take-up and enhances equity. So there's $1.5 billion in incentives over the next few years to help drive this initiative. And that's through the plans, but is really intended to invest in provider capacity and in delivery system infrastructure. Another really important aspect of enhanced care management and community supports is this initiative called PATH, or Providing Access and Transforming Health. There's some money set aside for capacity building for the prison and jails to help with pre-enrollment process, or pre-release enrollment processes so that people leave incarceration with Medi-Cal coverage. And then there's also some specific programs set up to help with community supports and ECM implementation. So the first of these is a program to help counties who are living through this transition from the whole person care pilot into these supports being picked up by managed care. It's not always completely seamless, and so these are resources to help counties not have to backslide and to sustain the capacity that they have as managed care picks things up. In Q2, there should be a technical assistance marketplace launching so that providers can learn from each other and from other resources to, how to do enhanced care management, how to offer these community supports, how to exchange data, how to get consent, how to speak Medi-Cal, as many of them are new Medi-Cal providers. In Q3, there's plans for funds for collaborative planning and implementation so that counties and regions and communities can come together and figure out together how they want these resources to be spent and how to build up the capacity across the patch, across the community to achieve their goals. And then in Q4, some resources for one-time infrastructure investment in data exchange, workforce development, things like that. So the PASS program is a critical part of this and has significant enhanced federal funding. The behavioral health reforms in 2022 are mostly about making the systems less rigid and smoothing payment to providers, and in turn improving access to patients so that kind of no matter where they enter the system, it's easy for them to get access. There's also a kind of first in the nation contingency management benefit that's being made available as an option to counties starting in July. And this is an evidence-based treatment for stimulant disorder, including methamphetamine. And we're pretty excited about that. There's also plans to apply in October for another waiver that will enable Medi-Cal coverage for specialty mental health services in residential treatment settings known as IMDs. This is very similar to what has been offered on the SUD side for the last several years and should help reduce the shortage of psychiatric beds. In terms of looking ahead to 2023, we see more populations in enhanced care management, as well as some other changes. So the population health management program that we talked about before that you see at the top of the pyramid, it's a really important shift for managed care plans, forcing them to kind of really know their full population, identify conditions, and proactively connect people to services. In addition, plans will be taking risk for institutional long-term care in a new way, and offering more alignment and integration for people who are eligible for both Medicare and Medi-Cal. New populations for ECM, so older adults who are nursing home eligible who want to transition to either assisted living or to home. And pending approval by CMS, an additional population around people transitioning from incarceration. In the BH front, kind of further work on standardizing screening and making those pathways in easier, as well as payment reform that should make the way that we pay for behavioral health more similar to the way that we pay for physical health, laying the foundation for integration of services at the point of care. So that's a lot of change. And we're, again, waiting to hear from CMS around the pre-release coverage and whether we'll actually be able to provide Medi-Cal covered services while people are incarcerated, or whether it'll be limited to ensuring that they have enrollment before they leave. As we kind of step back from all the individual details of these reforms, I think it's worth talking about some of the benefits or opportunities as well as the risks. So I'll start with kind of enrollees or beneficiaries. We would hope that with the implementation of CalAIM, people will find it easier to get needed services, face less inefficiency, and more equitable care and outcomes. I think the risk here is that it could potentially add another layer of bureaucracy without really moving the needle on these things. So that's something to watch. For providers, hopefully this will make the business case of being responsive and holistic much stronger, and reduce some of what some providers describe as the moral injury of dealing with unmet social need. So giving them the resources to be able to close some of those social gaps that they see and that impact health outcomes. I think we also hope that more providers will participate in Medi-Cal, including an expanded workforce of community health workers. and a bunch of new providers that offer these wraparound services. There are real risks on the provider side. I think in the near term, the changes in the transition could lead to financial shortfalls or uncertainty that ends up reducing capacity in this whole person care transition. I think in addition, we have to face the fact that we're asking a lot of providers at a time when they're already understaffed and really burnt out from the pandemic. For Medicaid managed care plans, the scope has expanded and brought with it much greater responsibility for a broader range of services and a new set of providers, and a new business case for addressing social risk factors, which has new risks to explore. You know, CalAIM's changes create heightened expectations. They also create a more level playing field, along with the ability to make apples to apples comparisons between plans that should make it easier for DHCS, for local leaders, and for advocates to hold them accountable. I think the risk here is that too much too fast results in uneven implementation that could worsen disparities. I'll just close with the fact that we think the vision is exciting and really, really important. Having a more cohesive system for people with the most complex needs and a proactive, equitable system that includes more accountabilities can really help address the equity gaps that we see in outcomes and quality. But I can't underestimate the size of the lift and the fact that this is going to take time. It's a huge, huge, huge change. So that is the end of my presentation. I will turn it back over for Q&A or for Mr. Margolin's presentation.
Thank you, Ms. Simon. I'm going to, just as a matter of sequence, I'm going to go to Mr. Margolin next to ask you to hang in with us if you can. I can promise you, you'll find Mr. Margolin fascinating. I always do. And after we've heard from him as well, I'll take time for questions and some back and forth with Supervisor Lee and me imposing on you and Mr. Margolin for your expertise. I would ask you to just be thinking a little bit in the intervening minutes about what I'll frame broadly as sort of the core question that I indicated I was thinking about at the beginning of the meeting, which is, so what does all that mean for our county? And of course, I understand you're not a Santa Clara County organization, you're a California organization, but I know you've been giving thought to what does all this mean for individual counties as they face the next 6 months to 3, 4, 5 years. And I will be trying to probe a little on that after we've first heard from Mr. Margolin. So let me say thank you. Thank you for your willingness and ability to stay with us. And Mr. Margolin, let's turn to you now for your take on where we're headed with Medi-Cal managed care, including but not limited to these CalAIM issues that we've just discussed in some depth. And again, I'm also thinking of the re-procurement process for the second plan, the commercial plan, as well as the potential expansion, the planned expansion and the potential expansion that's just been recently announced. Ms. Simon, thanks again. And let's ask the clerk to enable Mr. Burt Margolin.
Thank you very much, Supervisor Smitty. Am I on now?
You are live. Thank you.
Thank you. And thank you, Melora, for that excellent presentation. Between Melora's presentation and what you heard from Renee Santiago in November, you have a pretty clear sense now, I think, of what CalAIM is intended to be. I'd like to spend my time stepping back a bit to tackle two topics. First, I want to spend a little bit of time on sort of a 30,000 foot high overview of the two Medicaid structures that are driving the reform, Medicaid waivers and Medicaid managed care, some sense of what they are and some sense of how did CalAIM come from all of that? What does all that mean? A little historical background. And then I'd like to close by taking a crack at outlining, as you've suggested, Mr. Chair, some of the issues going forward that the board might want to look at that will impact how well CalAIM does. CalAIM is very ambitious. It has all the right objectives, but lots needs to go right for its potential to be fulfilled. It has to really work very well in a number of areas. So let's start with the waiver discussion. Why is most of this work being done through Medicaid waivers? It all starts with this key fact, which is that unlike Medicare, which is a national program, a true single payer program. Medicaid is composed of 50 individual state programs. Yes, there are national rules that bind them all together, but states have broad discretion on how they implement their program. And these state decisions about how to implement are, and this is no surprise, typically driven by the financial question of how do we access federal dollars. In this program, each state has to put up a match, state dollars to draw down federal dollars. And where waivers come into play is if a state wants to try something new, different, outside the box, these federal waivers allow a state to draw down federal money that would otherwise not be available, money potentially for transportation. Melora talked about some of the CalAIM objectives here that are not part of traditional Medi-Cal. So these are programs or services or expansion populations that Medi-Cal will not normally pay for, but through a waiver, you can draw down extra money. Your commitment is to do something innovative as in exchange for the dollars, and that's what waivers are about. They're typically 5-year agreements. California's first major waiver was a sub-state waiver. It applied only to LA County, and it was in 1995 that County USC was on the verge of closing. County was suffering a major financial crisis, and the Clinton administration worked out the first major waiver for California with LA County. Both Renee Santiago and I worked on that waiver at that time, and the county got the money to keep County USC open. It also got money to better coordinate care for patients and to allow federal dollars that were not available for outpatient care, for primary care, to be freed up from an inpatient setting and moved to an outpatient setting. It's a very early, primitive first draft of what 25 years later, CalAIM is doing in a much more sophisticated and comprehensive way. The LA waiver was controversial because it was one county only, and there was a lot of pressure to expand it. It lasted for 10 years, finally got phased out. And then in 2005, the state did what was called the hospital financing waiver, an effort to make some of the benefits of the LA waiver available to all public hospital systems in California. Now, why did public hospital systems have an elevated role in this 2005 waiver and in every waiver since? There are two reasons. One was that public hospital systems, such as the one that Santa Clara County runs, are at the core of the safety net. And has been historically a major uninsured population that depends upon these systems, and there's an incentive to use waivers to address that through public hospital systems. But the other issue is just more practical. Counties were able, because they're public entities, units of the state, in effect, subunits of the state, they were able to put up the state match and allow the state to draw down federal money without using state resources. So that financing advantage that counties have had historically allowed public hospitals to be at the center of these waivers. So 5 years later, 2010, the next waiver comes along. These are 5-year increments, and it's the bridge to reform. And this is the waiver that is developed right after the Affordable Care Act is passed. The focus at that point was to give the uninsured who would by 2014 be eligible for Medicaid for the first time, to give them an opportunity to be enrolled in a program that would provide them with some degree of coverage through the waiver. Again, not eligible for coverage without the waiver, but with the waiver, they could have coverage in a county system. And then in 2014, when the Medicaid expansion kicked in, this population could be then seamlessly rolled into Medicaid, which actually happened in 2014. 2015 comes along, and federal government changes its focus somewhat. Expansion of coverage is no longer the key priority, because we have an Affordable Care Act that, especially in expansion states like California, which fully utilize the Affordable Care Act to expand the Medicaid population, it's just a less central focus. Instead, what CMS begins to do in this waiver that was negotiated in 2015 is to focus on quality and outcomes, moving away from coverage, which is important, but now we have to focus, the federal government says, on quality of care, the outcomes. Are we really serving the patient population? And in that waiver, the whole person care pilots were negotiated. The idea here that there are social determinants of health that you can't simply look at clinical conditions and clinical treatments in a narrow medical sense and assume that you're dealing with the needs of a low-income population. That assumption was out of date, not practical, not working. And Medi-Cal 2020 pioneered a whole person care and a whole set of programs designed to ensure that care was delivered in a more comprehensive fashion. At the same time, the federal government was told in 2015, listen, this waiver mechanism, it may be your last because you have to find a way to fund these programs through your own resources. We're not going to continue to provide these injections of federal funds through the waiver mechanism. So the state took that seriously, and in 2017, 2018 began to think about developing what is now CalAIM, which is they wanted to continue what was this innovative, expansive approach to care that the 2015 waiver helped develop through whole person care, but they recognized it had to be done largely through state resources, not waiver resources, and managed care plans. The managed care system became, in the eyes of the state, the major and most desirable mechanism for driving system improvement. So it turns out that while CalAIM got developed through this process, that 2015 waiver was not our last waiver. President Biden was elected, and not only did we get CalAIM approved, and we have managed care now as the tip of that spear in terms of driving those reforms, we also have a waiver that still provides some level of public hospital funding, because again, going back to the 1995 waiver, all of these waivers have had as one of their goals the stability of the public hospital system in California. And while the funding in the current CalAIM waiver is significantly diminished from past waivers, there are still funding streams there that will help the county system. So CalAIM relies on managed care. And let me talk for a moment or two about managed care. This is a logical extension of the direction California has taken for the past 50 years. California was the first state in the nation back in the 1970s to incorporate managed care into the Medi-Cal program. California has always been ahead of most of the rest of the nation in relying on managed care. Now, in the early decades, this managed care focus was really about controlling Medi-Cal costs. That's what the state was more concerned about with in the 70s and 80s and even into the 90s. In CalAIM, we've now transitioned to a concern about costs. I mean, CalAIM is also about costs. Managed care does potentially cap costs and allow the state to maintain more control over costs. But there's this major emphasis on quality, measuring outcomes for the patients. It's a very welcome evolution and a much different kind of program than the state would have done 20 years ago or even 10 years ago. So the state did a major expansion of Medi-Cal managed care in the early 90s that we're still implementing today, and it relates to CalAIM, and I want to talk about it briefly. And the state developed three main models for how a county can deliver care. The first model is county organized health systems. That's where a county creates a single plan. Everything runs through one plan. Orange County is a prime example of how that's done. Then there's the two-plan model, which is what Santa Clara chose and still maintains. The county creates what's called the local initiative. It's the family health plan. The state certifies a commercial plan, the purpose of which is to ensure beneficiary choice. Again, county organized health systems have virtues, but there's always been a skepticism about pushing everyone into one plan. If there's choice and competition, in theory, more quality. And then the next option is geographic managed care. And geographic managed care is basically a system that applies mainly in counties where there's no public hospital system, and it involves multiple plans in a much more intense competitive environment. Well, it's important to note that the two-plan model was created not just to create that choice, in contrast to county organized health systems, but there was also a concern by the counties and the state about the financial viability of the public hospital systems. If you went to the geographic managed care, which is wide open competition, the concern was that too many patients could be siphoned off too quickly, too much revenue lost, too much service lost, and hospitals might close, and that public hospital system, which was heavily dependent upon Medicaid revenue, might find itself jeopardized. So The local initiatives were created by counties and given the right to, the counties were given the right to structure them for many reasons, but one of the key reasons was so they would have the maximum opportunity to retain lives within the county system and support the county safety net. Important to keep that in mind. So we have a complex Medi-Cal system. We now face the challenge of implementing a multifaceted, complex reform. And now let me close out my presentation by talking for a few minutes about some of the issues that the Board of Supervisors might want to focus on. Again, I picked 6. There are more, and you may decide to prioritize them in many different ways, but let me go through the 6 I've identified. So we've heard a presentation from Laura about the promise of enhanced care management and community supports. And to the extent they actually materialized as advertised, they will help the most vulnerable patients, the highest cost patients, get the care they most need, keep people out of hospitals, out of institutions. It's a great concept. It's moving whole person care into managed care. But as Melora pointed out, there's a discretionary aspect to this program. It's optional, and even in its implementation, there's a lot of broad latitude. So do the plans pursue an aggressive and effective strategy to actually make this a reality on the ground for the small population of highest cost health system users, or do they hold back? And are they cautious? That's something to look at and pay some attention to in this first year. Second issue is population health, which, as Melora pointed out, won't be implemented for another year. This will be a major challenge for health plans. One way of contrasting population health with enhanced care management and hope is that enhanced care management and the community supports focus on small population of most vulnerable people who are the highest system utilizers. Population health tells the health plans, listen, you've got to look at your full population of members, and we want you to be proactive in identifying risk factors by individual, by groups, by community, and adjusting the way you deliver care in a manner that responds to those risk factors and keeps your population under your care healthy. It's a major challenge. Some health plans attempt it now, many do not. It's new terrain and there's no guarantee of success, and that needs to be looked at. It's also kind of overlapping a little bit with the county public health function in that the county has a population health mission as well. So there's an interaction there that can be explored. Third point is two-plan model. Two-plan model needs to work better than ever before. It needs to be at its peak of performance. As I previously mentioned, it was always intended to facilitate a close cooperation between the public hospital system and the local initiative. With all these new responsibilities imposed by CalAIM, there are a lot of programmatic and financial issues to work through. How well does the county and family health plan navigate that terrain? Something else to look at. Item 4 is reprocurement. Now, this is the process that the state is utilizing to, in effect, rebid the contracts for the commercial health plans. There are 36 counties where this is going to apply. There are 9 commercial plans that currently have these contracts. There are other commercial plans that might like to get those contracts. It's essentially putting those contracts out to bid. The quality and performance of these commercial plans has not been evaluated by the state in a very, very long time. What the state decided here is that with the demands of CalAIM, they want to make sure that the managed care system in place, the part that they especially have control over these commercial contracts, is capable of delivering what is needed. So that's the purpose behind the reprocurement. They're going to put out an RFP in the next month or so. They're a little behind schedule. They're going to pick plans by the end of this year, may keep plans, may change plans. 2024 is the implementation deadline. And a key fact to keep in mind here is the state has announced that whatever new requirement it imposes on commercial plans will apply to all Medi-Cal managed care plans. So there'll be a ripple effect on the whole system. Fifth issue is the Medi-Cal expansion that you referenced earlier, Supervisor Simitian. Medi-Cal has doubled in size since the Affordable Care Act was passed. It's an enormous program. 14 million beneficiaries, 1/3 of the state population. Santa Clara County has roughly 400,000 people in Medi-Cal. Over the last few years, Governor Newsom has worked to expand Medi-Cal program to cover the last cohort of uncovered individuals, less major cohort of uncovered individuals. And they are the undocumented who don't qualify for federal financial participation. Federal government will not put them in Medi-Cal with federal dollars. They can't do that pursuant to federal law. So if you want to cover the undocumented, you have to do it through state-only commitment. In 2016, Governor Brown covered children, 250,000. In 2019, Governor Newsom expanded that to young adults, 19 to 25, another 90,000. Last year, the governor signed a bill to include the over 50 population among undocumented, 235,000 people. They'll be eligible to enroll in May. And in the governor's budget, he has said he wants to cover the 700,000 statewide remaining people between 26 and 50 who are not now eligible because they're undocumented. And he wants to, when he does that, achieve what he refers to as universal access. It's not coverage because there's no guarantee they're going to enroll. So the issue here is how well are enrollment efforts going in Santa Clara County? We had the public charge issue in recent years, which intimidated some in the undocumented community from wanting to enroll in any kind of program. Is that happening now? That public charge is less of a risk, is not a risk, or is it not happening? And the last issue I want to talk about is, in final comment, is the least discussed aspect of CalAIM, almost never discussed, but should be at least noted. Past waivers have heavily focused on providing resources to sustain public hospital systems. And we've talked about how the two-plan model was actually designed to help keep public hospital systems afloat during difficult and challenging times. Now that we have diminished waiver funding going to public hospital systems, still some there, but much less, and we have a CalAIM program that has less focus on public hospital systems, what does all this mean? Under this elevated managed care focus with CalAIM, counties will have less control over the flow of dollars. The state will be, in general, more passive about managing all of this because they're turning this over to the health plans. Health plans will have an enhanced influence over how the safety net is funded. How will this impact the financial stability of public hospital systems? Now, it's not an issue today. Funding is adequate. Public hospital systems are in relatively good shape today. But if we're thinking ahead 3, 4, 5 years and looking at this waiver maybe being the last waiver, the issue of how CalAIM works in practice versus theory, and other uncertainties involving state finances, it's just something that should be on the board's radar. That completes my report. Happy to join Meloria in responding to any questions or comments. You're muted, Supervisor.
I'm committed by our 2-year anniversary of Zoom meetings to not having that challenge anymore. Thank you very much. I should just indicate, and I want to call them out, we have some background materials from both our county administration. Dr. Smith, I believe I saw you on the call earlier, yes?
I'm here, yes.
Thank you.
Listening intently.
Well, and we're going to use you as a resource for questions. So I wanted to give you a heads up on that since we have the written report. Thank you. And then I believe we also have Christine Tomkala from our Santa Clara Family Health Plan. Ms. Tomkala, are you available here if we have questions as we work our way through this conversation?
Yes, I am. Thank you.
Thank you again so much to both of you for joining us. And Supervisor Lee, what I want to do is tap the 2 panelists plus the 2 administrators that I've just introduced here as well. I do want to take the prerogative of the chair, Supervisor Lee, to ask a couple of questions first, and then go to you for a couple, and we'll go back and forth. So we'll try and wrap up by 3:30. Let me just ask all of the 4 people, actually, and I'm going to start with Mr. Margol and then go to Ms. Simon. And if it's not your area, you want to pass, that's fine. But Mr. Margol, I am wondering, you talked about the re-procurement process. So who is it that's actually going to make a decision at the state level about which commercial plan is the second plan in the 2-plan system?
So it's going to be done by the California Department of Healthcare Services. I don't know offhand the individual who specifically has the authority in that structure. Perhaps others on the Zoom can identify the individual whose point, but it's done by the state, and that's the process.
And presumably there is some criteria by which the organization is selected if there are multiple bidders. Yes.
Yes, they're going to have an RFP. They did a draft RFP earlier in the year that people commented on, and the formal RFP is going to come out. It was supposed to come out, I think, end of last year. Now it's scheduled for maybe February or March, and it's going to be very specific, asking people to respond to things that relate to enhanced care management, things that relate to community support, things that relate to population health care management. I think some of it is going to be more generic and quality related, unrelated to CalAIM, but I am assuming there's going to be a specific set of requirements that relate to CalAIM.
Got it. And Ms. Simon, any thoughts there as well about how that process works? I'm just, we have grown accustomed to having the two plans that we've had. Now, my understanding is there are 2, 3, maybe 4 different plans that will be in competition. Any notion about how that selection process gets made?
I'll defer on that one. It's not my area of expertise.
All right. Dr. Smith, and then we'll go to Ms. Tomkala.
I want to just really make sure that we're talking about the same thing. The RFP will apply only to the commercial applicants in the 2-plan model. So in our case, it's been Anthem Blue Cross. And obviously others can apply. It does not apply to the public health plan option, which in our case is family health plan. And those are the 2 health plans in the 2-plan model. VMC, which sometimes gets confused, is not part of the 2-plan model in any way, except that it has relationships with both Anthem Blue Cross and Family Health Plan, and closer relationship, obviously, with Family Health Plan in that we accept lives that are delegated from Family Health Plan to VHP for service. So to be specific, your question addresses the commercial plan, not the public plan, and the state will make the decision based on the RFP. And I don't think we know exactly the criteria because in previous years it was more limited to simple mathematics. Now, because of CalAIM, it's at least the draft RFP has much more to do with operational requirements and measurements. So it'll be challenging for the commercial plans to actually meet those requirements, and who applies is a big question mark, and how they choose is also a big question mark.
Thank you. But presumably, and I know that's a big word, but presumably if Anthem applies again, Blue Cross applies, Healthnet applies, somebody else applies, the folks at the Department of Healthcare Services will have some pre-established criteria that is designed in their estimation to rank applications in terms of who is best equipped to deliver on the expectations of Medi-Cal managed care, including CalAIM, for our county. Yes?
Yes, just trying to make the point that the commercial plans historically have not had the access to operational requirements in order to meet the CalAIM operational capacity in order to meet the CalAIM requirements.
Right. Want to come back to that in a minute. Thank you. Ms. Tomkala, anything else on that piece, the reprocurement process?
Generally, I think what we know about it has been covered by my colleagues here. I will note that as far as the last thing we've heard, the RFP is due to be released February 2nd. As has been mentioned, it has been delayed. Whether or not it's delayed again, we don't know, but that's the latest date that we have heard is February 2nd for release of the RFP and then implementation starting January of 2024.
Thanks. And then back to Dr. Smith on this re-procurement issue. My understanding is that at least one potential plan competitor, Healthnet, has been in touch with our county and has been in negotiations with us so that they would be better equipped if they were a competitor in the process. What can you share with us about that and whether other plans have or will reach out to us for the same reason?
Initially, other plans did reach out to us, and Healthnet did enter into an agreement with us. The reason for them to do that is because, as I said, they don't historically have access to the operational capacity and resources to actually meet the requirements. Whereas we, as a delivery organization, the county health system, do have access to those services, such as housing, social services, all of the other behavioral health services that are needed to actually compete in CalAIM. We do also obviously have a close relationship with family health plans. So in some real sense, it's very likely that the county health system, VMC in the health system, is going to have relationships with both family health plan and whatever successful bidder there is.
And what's the current status of the negotiation with Healthnet in terms of their potential ability to access services from Santa Clara County as a corporate entity in order to be a more robust applicant?
I can't give you the extreme details, but I can tell you that it's very similar to the concept we have of the relationship we have with Family Health Plan, where certain services that are required to be competitive in CalAIM, such as behavioral health, rehab, managed care, substance abuse, other social services, housing, other services that we provide as a county would be available to the to Healthnet. And obviously, like I said, if any other commercial plan desires to apply and is interested in partnering with the county, we'd certainly welcome that, because from a county perspective, our priority is to assure high quality services to all Medi-Cal members, not merely the ones who are covered through Family Health Plan.
And the agreement, if any, with Healthnet comes to our board when, where, how, just to refresh my memory, or already has. If I'm forgetting some piece of this, please refresh my memory.
It would come basically after the bidding process. At this point, it's a tentative agreement with concerning the issues that I just brought out.
Got it.
It wouldn't be finalized with board approval until after there was a bid and a successful decision making at the state level. So you can consider it sort of like in the land use world, where we have quote non-binding agreements with a owner of a piece of land that we're going to purchase. We come to the board after there's evidence that the purchase will be consummated. There's no reason to come to the board before that.
All right. But other plans have not yet approached or engaged you in similar conversations, as I understand it?
Initially, there was interest, and then they dropped out. So at this point, yes, it's just one.
Okay. Thank you for that. Well, I'll follow up some other time. I don't want to devote too much more time to that just because we have other ground to cover. Let me start with Ms. Simon. And again, Ms. Simon, if it's not your area, feel free to pass it to the next panelist, then Mr. McGowan. Ms. Simon, we have a staff report from our county staff that suggests that I believe it's May 1st edition of new potential enrollees for Medi-Cal managed care could be as many as 12,000 folks in our county. When someone said 700,000 could be added by the proposal that Governor Newsom made, which I gather could be as early as January 1st of 2024. I am doing some quick back of the envelope math, and that tells me that our county could be looking at as many as 35,000 more potential enrollees if that effort moves forward. What does this growth in Medi-Cal eligibility mean to counties that you have observed, worked with? I'm going to drill down to Santa Clara County in a minute, but is that good news, bad news? To some it may sound like more work. To others, it may sound like a broader patient population and a bigger base. Others might say, well, if we're losing money on every one, we're not going to make it up in volume. What's your assessment of what that means for counties up and down the state?
I would definitely defer to others on this, but I think there's real precedent, so we can kind of know what to expect from kind of prior expansions that have happened. And I believe that 700,000 is for the population between 26 and 50. And so there's probably a lot to learn from the Medicaid expansion would be a similar population.
Mr. Margolin, thanks, Ms. Simon.
Well, I think it's good news in that while there are operational challenges, I'm sure, to absorbing that size population, Governor Newsom's vision of universal access is very consistent with the Santa Clara County vision. Long before Governor Newsom was governor, Santa Clara County's been at every possible opportunity has worked to expand access, expand coverage. And now we have this last increment of the population that can't qualify for Medicaid. They still need health care. They come in later than they should with conditions that have not been treated as early as they should have been. There are human costs to that. There are financial costs to that. Having them enrolled in Medicaid, Medi-Cal is a good thing. And operationally, I'm assuming here that it can be handled because the other incremental expansions have not created a problem. The only issue has been that I'm a little bit curious about is public charge. The fear of an undocumented person during the Trump administration signing up for a public program. There was probably something of a chilling effect back then. Now that public charge is to the side, I'm assuming that this population will want to enroll to the extent it's made available to them.
Dr. Smith, as the administrator, county executive for Santa Clara County, what is that kind of potential increase in terms of numbers? 12,000 by your estimate for May of this year, and then 35,000 more within a year or two by my estimate if the governor's plan moves forward. What does that mean financially and operationally for us?
Well, this is an impact upon our delivery system. So when I say delivery system, I mean the 3 hospitals and the clinics and our relationship with the community clinics. And it's a very good thing. From a policy perspective, we want to participate in providing care for the Medi-Cal beneficiaries. Our job is to take care of the uninsured and inadequately insured and those individuals who are insured by Medi-Cal and Medicare. So, from a policy perspective, it's a great approach. From a financial perspective, presuming that the CalAIM funding and approaches to funding through the waiver all are worked out, it will also be a good thing because in our delivery system, Medi-Cal is our major source of revenue, both individual and with supplemental payments, and having a coordinated system which is envisioned by CalAIM, where we have social determinants of health coordinated with the medical care, is something we can certainly do financially and operationally. So it's a very good thing for us.
Dr. Smith, historically, I have, looking now at the financial piece, putting the policy benefits aside for just a minute, I have understood, and I want to make sure my understanding is a correct one, that since historically and legally, the county is the healthcare provider for the indigent population, if I'm remembering correctly, it's the Welfare and Institutions Code, that it is to our economic advantage to have people showing up with some insurance product, including Medi-Cal, rather than with no insurance product or any other resources. Is that gross oversimplification fairly accurate?
Pretty much, with a few nuances, in the sense that, as was pointed out earlier, Medi-Cal has expanded to cover individuals who historically would be considered uninsured, like people who are not documented, or individuals who don't have insurance but are pregnant. I shouldn't say individuals, women who are pregnant. And then emergency Medi-Cal for individuals who aren't, quote, insured for broad range Medi-Cal, but are insured when they have an emergency. We don't have a large proportion. As a matter of fact, we have a very small proportion of commercially insured individuals who get their care provided at VMC or the other hospitals, but it's larger than would typically be true for most public health systems, partially because we purchased the two hospitals that have a significant portion of commercially insured individuals. So those caveats just confuse your general message, and your general message is correct. It's better to have people who are insured than uninsured, but we're responsible for everybody.
And Ms. Tomkala, and I'll go to you finally, and then I'll turn to the very patient Supervisor Lee. Ms. Tomkala, what does this mean, this expansion, this growth in the population for Medi-Cal, and in our case, Medi-Cal managed care with a two-plan system? What does that mean both operationally but also financially for the family health plan?
We would welcome the expansion. I think it's the right thing for the community, and I think the health plan can handle that expansion. The one thing that hasn't been mentioned that I am wondering about is there may be some additional stresses on timeliness of specialist appointments, for example. If some of these folks are now have additional care available to them. I know that some specialists, there are already some significant wait times for members to get in, and it may add some stress there. But in general, we think it can be handled, and we welcome the opportunity.
And let me drill down a little more on the financial side. Financial impacts, if any? Good news, bad news, challenging news?
I think it's good news, and we don't have all the details yet, but I think in general it's good news financially.
Thank you. Let me turn now to my colleague, Supervisor Lee, who will have questions of his own that may be on the similar topics or may be very different indeed. We'll find out in a moment. Supervisor Otto Lee.
Thank you very much. These are certainly really insightful questions. This CalAIM is certainly an amazing program that's coming down the pipeline, and there's a lot of things that we're still trying to learn. So let me go through the questions I have for now. For Ms. Laura Simon, my question I have is for the path. You talked about the one-time infrastructure investments. Can you give us a little bit more explanation, and what type of opportunity for investment do we have to expand on?
So a lot of the details are still to be forthcoming from the department. We kind of know that there are 5 categories of funding that they're making available, kind of some for whole person care transition, some for kind of technical assistance for individual providers, some for collaboration, some for infrastructure, so workforce data exchange, and then finally some for the sheriffs and the prison systems to be able to do pre-release enrollment. The specifics of what the applications will look like are still things that we're waiting for from the department.
Okay, great. On slide 12, you have a bullet point on the potential for pre-release coverage and reentry supports. Will you be able to share more detail what those services supports are?
Absolutely. So historically, there's been a kind of a mandate that you can't provide Medi-Cal or Medicaid coverage for people who are incarcerated. And what California has proposed to CMS is a limited set of services for people in jails and prisons. And the idea is that they would be able to kind of get connected to that enhanced care manager prior to their release. They'd be able to leave with the medications and any durable medical equipment that they need. And I think there's also a provision for some telehealth inside the jail. But whether that will be allowed and what exactly the scope of that is still something that's being worked out and negotiated between DHCS and CMS in Washington.
Great. So just trying to cover that gap that has been existing for all this time for coverage. Great. Thank you. My next question is actually for Mr. Margolin. Of the issues you've highlighted regarding the Medi-Cal managed care, CalAIM, and the reprocurement, which issue would you think is the most urgent for us on the Board of Supervisors to monitor and review?
Well, one issue that comes to mind is this transition of whole person care and the extent to which the plans are going to be taking on with enhanced care management and the supports, the community supports, taking on the management of this very vulnerable population. There's differences in criteria between what whole person care established and what the plans are now going to be applying. And as we discussed beforehand, there's this area of discretion about what supports to use and how to use them. So monitoring, paying some attention to whether or not that transition is done properly, goes well. The plans not only have the resources, but use the resources aggressively, appropriately is something I would prioritize.
Okay. Now, as mentioned earlier, there's an ongoing question about the financial stability of the public hospital system, especially down the road when the managed care and these waivers might be gone in a few years. There's going to be some type of a day of reckoning, as you said, and that we need to reevaluate the financial stability of our public hospital system altogether. Can you maybe elaborate on this a little bit more and any type of suggestion that we need to get ahead of this situation?
Sure. Good question. So I didn't mean to suggest, I want to clarify again, make it clear again, that there's no immediate threat to public hospital systems financially, thanks to the waiver, thanks to CalAIM, thanks to other infusions of dollars from the federal government. These systems are relatively solid now and will be for the next few years. What I was trying to raise here is that historically, going back over 30 years, these systems, our system and others, have gone through periods where federal and state funding has been withheld or diminished, the economy, other factors, changes in federal rules. And we've used in the past these waiver mechanisms to kind of fill in the gap. We're not going to necessarily have the waiver mechanism going forward. We now have this reliance on managed care, which has its own kind of challenges potentially for providers down the road. And I'm trying to just flag this as an issue we should be mindful of. Now, in terms of working out solutions, you should know that Santa Clara County is a member of the California Association of Public Hospitals and Health Systems. And working with the other systems around the state, this is sort of internally a topic of ongoing discussion. And there are discussions that have gone on over the last year or two with the governor's office, with the Department of Healthcare Services. They're aware of the fact. In fact, the governor in his budget, if I'm not this year, actually has a reference to the public hospital system funding needs as an issue that needs to be looked at. So the governor's engaged with CAPH indirectly and directly with Santa Clara County. And they're going to be, there's not an immediate crisis, but it's something that everyone is aware is a potential problem down the road. And there are discussions underway.
Thank you. On the issue of Medi-Cal services to the undocumented residents, how do you think our county currently is doing, and how we could expand it more, given the upcoming changes in the CalAIM criteria and all that?
Well, I would, as far as how the county is doing currently, again, I would probably defer to Dr. Smith or others on this call to address that. That's sort of a programmatic issue. As far as, moving forward, again, I'm optimistic this is going to be a very good transition. We do have to be, mindful about the uptake on the part of this population. Are they really going to be coming into our system and enrolling? We want them to enroll. So the county should be thinking about ways to encourage enrollment. But I'll defer to Dr. Smith on that question. Dr. Smith, do you have anything to add?
Go right ahead, Dr. Smith.
Enrollment is something we're always concerned about for a number of reasons. I think Ms. Tomkala will also support the concern that the process of enrollment has been created in such a way by the state that it's a little disorganized. Enrollment happens through both social services and sometimes through the hospitals, sometimes through other venues. So we always want to make it easier to enroll, and we try everything we can to coordinate that better. I hope that answered the question, Supervisor. If not, put it to me again.
Sure, we could probably do it again later, since the time is kind of tight. I just have a couple more I want to address today. Just before the holidays this month, Judge Manley informed our office about the opportunities to take advantage of CalAIM funding for behavioral health and rehab facilities, building residential and detox beds, discharge planning, and supporting individuals transitioning from incarceration. So what is counties, our administration currently doing or will do to address these areas highlighted by Judge Manley through the CalAIM program?
I'm sorry, you cut out on my computer a little bit. Could you repeat the question?
Sure. So the question is, we're trying to take advantage of the CalAIM funding for behavioral health and the rehab facilities, building residential and detox beds, discharge planning, supporting individuals transitioning from incarceration. So question is, what can we do or will do to address these areas highlighted by Judge Manley through CalAIM?
Yeah, that's one of the, a number of the great advantages of CalAIM. Behavioral health payments that will change in their methodology, the addition of custody care, and also expansion of substance abuse services. So you'll be seeing, as we find out more from the state about the exact nature of what happens with regard to CalAIM, you'll be seeing requests for additional staffing and operational changes in all of those areas. We're very hopeful, particularly with what we're hearing from the state, that that'll help us quite a bit. We obviously lose a lot of money on healthcare and behavioral healthcare in the jails particularly, but also, even though we're an overmatched county in behavioral health and substance abuse for non-incarcerated individuals, we still have great need in the community. And so we'll plan on using those new resources for expanding services in that way.
Okay. And how does CalAIM, you think, align with the single payer initiative that's been discussed?
I think I'll give my opinion, which is more of a colloquial opinion, but then I think you'll have to go to the experts on the line to actually give a thoughtful and meaningful answer. Since I've emotionally and from a policy perspective, always been in favor of single payer, I think that CalAIM's a positive step. Obviously, lots of details need to be worked out, particularly financial details, but I've strongly been a believer that the more we can treat healthcare as a right or a service to our community, and the less that we can treat it as a profit margin, the better off we are. And single payer focuses on trying to eliminate the profit margin if it's done correctly. If it's done incorrectly, it makes it worse. But the experts on the line, Bert and others, can give you a more thoughtful answer, I think.
Well, I'm not sure my answer is more thoughtful, but I have an additional thought, which is, and it confirms what Dr. Smith just said, that it is consistent with single payer and that it's an effort to standardize care on a statewide basis and provide greater access and equity. So that's consistent with with single payer goals. It's inconsistent with single payer in that the methodology or the driving mechanism, which is managed care, including all of these commercial plans, which is not to say that they can't do the job and do it well, but that's not single payer. Single payer is government run. So as the governor navigates his single payer commission and the bills in the legislature, integrating the CalAIM operational detail with what those bills would call for is going to be a little bit challenging.
Thank you. And I'll go and turn the floor back to you, Chair Simitian. Thank you.
Thank you very much. I want to focus on what I'm going to call the 12,000 coming soon and the 35,000 who may be coming soon. And there was a little bit of conversation already about how we engage those folks and enroll them. And Dr. Smith and I think Mr. Santiago's on the screen here somewhere, if I remember correctly. Maybe not. There he is. Either of you gentlemen, my recollection is that, maybe 10 years ago, before we went down this Affordable Care Act, Covered California, Medi-Cal expansion path, we had something like 200,000 uninsured residents in Santa Clara County. We have been chipping away at that with tremendous help, obviously, from the Medi-Cal expansion and Covered California, the Affordable Care Act, the further subsidies to Covered California and the Affordable Care Act possibilities, but that we were still at a place where there were about 80,000 uninsured in the county. And that was, of course, Supervisor Lee, one of the things that was impetus for expanding PCAP eligibility was a way to get healthcare service to some potential 30,000 of those 80,000. But it sounds to me like if we got to the 12,000 and the 35,000 who may be coming, that would be a huge dent in what remains in our uninsured population. Mr. Santiago, Dr. Smith, are my numbers in the ballpark? And if I have conflated or confused, please feel free to correct me here in the committee. I want to make sure I've got my understanding right about the order of magnitude before I go to the next piece of the question.
Renee, why don't you answer that one?
Yeah, no, absolutely. You're definitely in the ballpark. If you recall, there's one thing, as Dr. Smith referred, there's one thing to become eligible and there's quite another thing to become enrolled. So I think that's one of the primary issues, because even though undocumented are not eligible and they would become eligible, it doesn't necessarily mean that they become enrolled, because right now, even if you're a legal resident, there's a lot of uninsured just because of the process. So I think this is something that obviously we have to keep in mind. A couple other things that we also need to be mindful. One of them is we're operating under the public health emergency, which has kind of stopped redeterminations. And if you recall, the redeterminations creates a churning because people go from employment to non-employment and a variety of different status throughout the year. So that will still be a dynamic after COVID in terms of how much churning and potentially people dropping off, being eligible for Cover California, maybe not, following through in Cover California and falling in the gaps. So that's one of the dynamics that we're going to be looking at as well.
Well, so thank you. That's helpful and it leads nicely to my next part of my question, Mr. Santiago, which is, so it would seem on its face to me then that means that we really do need the family health plan and the commercial plan, whoever that turns out to be. And right now it's Anthem. So in the moment, to be very aggressive and ambitious about enrolling and market outreach. Am I reading that right?
No, absolutely. I think it's important to have the Medi-Cal managed care plans keep people informed, the importance of continuing and eligibility as well as enrollment. There's also, as your committee has emphasized, working closely with social services and our community-based organizations so that all the collaborative partners are unifying in our messaging and spreading the word to all the target populations.
Well, I guess I would ask Dr. Smith and you if we could, and we've talked about this at prior meetings as you've referenced, Mr. Santiago, and thank you. But if we could get an update off agenda that just indicates here's what we and our healthcare partners are doing to reach out to those 12,000 folks, because the more of them we can enroll, the more we push that number down. And then also your preliminary thoughts about, and I know it's just happened, but your preliminary thoughts about what we might want to start thinking about in the way of planned outreach and enrollment engagement for the 35,000 extra folks that will be coming to us if the governor's proposal moves forward. I think that would be helpful. And let me go to Ms. Tamkala and just say, or ask her what her thoughts are about how we reach this new population or newly eligible population, I guess I should say. Ms. Tamkala, do you have thoughts about that?
Yes, and certainly it's yet to come, so we have to have more specific conversations. As Dr. Smith mentioned, the health plans themselves don't typically are not responsible for enrolling new members. So we have to rely on the county and others. As a health plan, it's an issue we care deeply about. We try to work with our community-based organizations and some of their initiatives. We also have a couple multilingual enrollment coordinators, if you will, at our new Blanca Alvarado Community Resource Center to assist the community in being aware of their benefits and helping them get to the right plan, whether it's Medi-Cal or Covered California or what have you. I would see that we may continue to expand that on a personal level outside of our Medi-Cal plan responsibilities. And again, working with the community-based organizations that can best reach these individuals who are currently uncovered and convince them that it's safe to enroll in Medi-Cal.
On that note, let me go back to Ms. Simon and Mr. Margol and say thank you both very much. Same to Ms. Tamkala and Dr. Smith. But I do, of course, have one last question for you all, and I will, I hate to frame it in the somewhat negative, but I'm going to put it to you this way. We've talked about some of the challenges, but as we look at the combination of reprocurement and the CalAIM rollout and the expansion of Medi-Cal eligibility, what's the one thing that keeps you up at night, that you worry most about in terms of making our way through the coming year successfully? Or if you want to offload it, what's the one thing that should keep Supervisor Lee and me up at night as we think about these challenges and others? Let me start with you, Ms. Simon, and feel free to take a statewide view here if that's helpful.
It's a good question. I think that I think this is an unprecedented opportunity in terms of the amount of federal and state resources that are flowing down. You know, we happen to be in a good place in terms of the budget at the statewide level. It's not always the case, and the pain is often kind of pushed down to the counties. To really take a step back and think about what are your community's needs and where should this new money go, and you know, where are the pain points that are, you know, that have historically been difficult to fund, that there are now federal resources available to. So I think to kind of frame it, you know, I guess one concern I've had is that counties won't do that work collaboratively and do it together to take advantage of this opportunity.
Thank you. Mr. Margolin?
I have a similar response in that, as was just pointed out, this is an incredible opportunity in terms of resources, funding, political will, state, county, federal collaboration. And my greatest fear is that through complexity, overconfidence, miscommunication, as Melora just suggested, it isn't implemented as well as it could be. And the concept of doing this gets discredited. That's the concern. We have to really take advantage of this and work together collaboratively.
Got it. Dr. Smith?
What keeps me awake is that it's very hard to implement change like Cal-AIM on a statewide basis, particularly when you have to have the cooperation of the federal government and multiple branches of multiple districts and branches of state government. So what worries me the most is that the changing political climate at the state level and the federal level could blow up this entire proposal with a very risky endeavor. So I guess the worry I have most is the politics.
And Ms. Tamkala, I'll give you the last word before we go to public comment.
Thank you. I would have to say Cal-AIM and the concept that, you know, Cal-AIM is going to be continued hurdles that we need to achieve to get to the ultimate Medi-Cal reform that's anticipated. And so the question is it too much, too fast? As I think Melora was the first one to raise that on the call today. And so they're all great programs, but there are fairly short timeframes for as big as the lift is. So there's lots and lots of work to be done if we want to be successful in this. So that would be what keeps me up at night.
Thank you. And thank you all again to our two invited panelists, plus Ms. Tamkala and Dr. Smith. Very helpful review of where we've been, where we are, and where we're headed. We are only obliged to receive the written report and oral comments, and we can do that without a vote in the absence of any objection. Hearing none, so ordered. And then let me just check with the clerk to see if we have anybody wanting to speak under public comment for this item.
I have two hands up.
All right, let's ask each of those folks to speak, and let's give them a minute and a half, please.
Okay, just a moment to adjust the timer. And then we will take comment on item 2.
This is on item 3, the changes to the committee's agenda. There were none, so, all right.
Our first speaker is Urvish Kumar Mehta. I've unmuted you. Please accept the unmute. You'll have 1 minute and 30 seconds to speak. The timer will start when you begin speaking.
Board of Supervisor, what I wanted to mention about is the changes that is coming to the behavioral health, and as well as to the new California laws that is providing the reform. Now, it is important to note that after the COVID-19, what are the changes and the reforms that has been made into the system? We come up with the new plans. We have come up with providing the necessity and the right medical resources to seniors, youth, as well as the mid-class and all age resources, where we need to provide the vaccination at no cost. However, if they need any medical aid, they would not have to pay anything out of pocket. They have the right set of a coverage to do that. Now, also, I wanted to mention about Senate Bill 855. The California must, deserve a recognition for the Senate Bill 855, which is for legislation which proving a critical gap in the mental health and behavioral health and forces family not to pay for the life-saving care. Many health plans determine the coverage based on the medical necessity. The problem is that they define medical necessity using their own internally developed criteria, not just the recognized standards of care. So we need a plan which basically define a standards for people not to pay out of coverage and not from their savings. Instead, it should be providing a right set of clarity. Thank you very much.
Thank you, sir.
Our next
And our
speaker
next-
is Mike Rogers. I've
Go right
unmuted you.
Hi, thank you, supervisors and speakers here today for holding this great content on really important stuff that's coming down locally and across the U.S. I've been working with the Health Advisory Commission in recent months, and specifically with Dr. Ken Horowitz, the vice chair in the Chronic Disease Subcommittee, on something in our work plan, which is focused on functional medicine and integrated nutrition. Very interested in the goal is to kind of develop a plan for a pilot, and where it would intercept is in the most neediest parts of the county. Doing research in this area, we've had speakers come in. PAMF actually offers functional medicine in the Suter system and has programs, and at least 3 of the commissioners, myself included, have engaged with the functional medicine capabilities in PAMF. But we're very interested in seeing how this would fit into the larger context of whole person care, of which I've observed at least 3 or 4 presentations on in the last year from different entities here, but very interested in something that addresses the root causes of chronic diseases, which represent 75 to 80% of healthcare costs and are in much higher proportions in the Medicaid targeted communities at all ages. So thanks for your time, and thanks for the focused discussions today.
Thank you. All right, I believe that completes the item number 3 comment. And then we have item 4, which is just general public comment on non-agendized items that are properly within the jurisdiction of this committee. If there are speakers there, let me check with the clerk to see if we have any.
I don't have any more hands going. I do have one request.
All right, just one request, and let's limit that to a minute today, please.
Thank you.
Only because we're running a little late. My apologies.
We'll bring up a 1-minute timer. When the timer is up, our speaker will be Urvish Kumar Mehta. I've unmuted you. Please go ahead.
Thank you very much again to all the Board of Supervisors, city staff, and as well as the respective Santa Clara County Health Department. Also, wanted to mention about the new law, which is bolstering the Mental Health and Behavioral Health Equity Act of 2008, which require insurers to cover the treatment for the behavioral health and substance use disorder no more restrictively than the treatment of the illness of the body. Now, it is equally important to make sure that the families, they wanted to make sure that, they need not to, take any savings or anything out when they are paying for the behavioral health. Also, last year, federal court in California ruled that the United Behavioral Health had wrongly denied the coverage for more than 50,000 patients. So we really need to define the right sort of a standard that the agencies that we are adhering to get the medical plans for. We really need to focus on what judicial system is also emphasizing and highlighting the facts.
That concludes public comment.
All right, thank you to our speakers. Thank you, Madam Clerk. Thank you again to all who participated today, and that completes our agenda. So without objection, we are adjourned. Take care, be well.
Recording stopped.